Before we get into the show and introduce today's guest, I would just like to thank United Medical Credit for being sponsors of this podcast and of the business of dentistry. As a matter of fact, they have a special offer for business of dentistry members, 0% merchant fees for the rest of the year, and 30% discount for life after that. You can get that special deal by either going to docoffinvestments.com and clicking on the deals section, or by going directly to www.unitedmedicalcredit.com/TBOD. Thanks again, UMC.
Welcome to the Dear Doc podcast, where we will discuss the business of running a dental practice with a panel of experts. Now, your host, Dr. Christopher Hoffpower.
The next level would be the phenolics. Yes, people have reaction to phenolics. They're not used in daycare centers, in neonatal wards, and so on. Okay. The lowest one, which has been cleared by tweaking, are the quaternary ammonia compounds. Okay. 20 years ago, quaternary ammonia compounds were only used to clean floors. Okay. But they tweaked it. Now it's the most, because of marketing, it's the most popular one. And everybody kind of challenges me on that. And I said, well, you listen to what you want to. But at the same time, on the instruments, you need to soak the instrument. We'll talk about the instruments and soaking the instruments and so on, in instrument reprocessing. But a lot of people have started, applying a surface disinfectant on instruments right after it's used. That's an overkill, but that's okay. They soak it, that's a good thing. And then they, sonicate it or use a machine to wash it and then stick it into autoclave. Those are good. But when we spend hundreds and thousands of dollars a year on a disinfectant, choose the best. There's no two ways about it. The claims are very different, And then environmental surface barriers are the next topic, you've got to think about. You've got to think about efficacy versus environmental effects. When I walked into Texas A&M College of Dentistry, they were, in 1997, they were bagging pretty much everything, including the hoses all the way to the handpieces. I said, dudes, where this plastic is going? There's no recycling of plastics in dentistry. It's all going into the landfill, south of Dallas. And those landfills are growing taller and taller. I didn't know that they were landfills. I thought they were little hills and mountains in a flat plain. I thought probably this is interesting. And then I asked my friend, he laughed at me and he said, those are landfills. That's the waste which comes from DFW. I prefer using a disinfectant and wiping it down and only using the barriers for very critical areas. I'm not talking of Spalding's criticality of surfaces. I'm talking of, let's say you can wipe down your hand, you can wipe down your handles. You can't wipe down the light switches because, those you can use a barrier, a small barrier out there. Or you can have, sensor handpieces where you wave your hand, switches where you wave your hand and then the switch goes on and off. Those kinds of things. Most of your surfaces can be wiped down between patients. In early 2000 and late 1990s, somebody came up with an algorithm and said, well, you waste 2 extra minutes per chair by wiping it down. Why don't you use a barrier instead? You can save a whole bunch of money. I said, okay, fine. Whatever sells, it will sell. But today, what are people doing? They're wiping it down and putting the barriers on. So you need to do one or the other. Okay. So I leave it to people. Now, barriers also are eyes. You need barriers for your eyes. And I talk about curing lights. When you have a curing light, which wavelength is 380 to 530 nanometers, and you stick it in front of your eye for about a couple of minutes, it will immediately start macular degeneration of that eye. You got to use eyewear, one for the patient, one for the assistant, one for yourself. To those orange ones which make you look like a bumblebee, yeah, those. And for those people who say that, oh, I use loops, there are loop inserts with the same blocking wavelength by the material which are available. I talk about lasers. I've seen lasers, the glasses for that, they cost about $250. I've seen dentists using a laser with an assistant using plain glasses. The assistant has to have those glasses too. So these are some of the things which I see missing out, Chris. It's sad, but it could be done, but they don't know better. I do not blame anybody, but what has happened is, in fact, the dental safety training has been put on the back burner and forgotten. Okay, and the oven is not even turned on. So it's kind of sitting and gathering dust. Then personal protective equipment. Before COVID happened, everybody had a cookie cutter thing. For every single patient, irrespective of the procedure you're doing, they were wearing full PPE, head, a bonnet, goggles, a mask, gown, and gloves. And I said, why are you wearing this for dry procedures? I served in oral diagnosis and treatment planning. We hardly use the air water syringe out there or a handpiece there. All I said to my students was, use plain gloves. If you're wearing prescription glasses, go ahead. That's it. And if your mouth is smelling, chew gum. There's nothing wrong in that. And just use plain gloves. And those people who are afraid of gleek would, wear a mask and eyewear. That's all. I've never been gleeked on in 40 years of my dentistry. Okay? Because you lay the patient down, and that has to be really powerful gleek. Okay. So you only use full PPE when you start using a handpiece, an ultrasonic scaler, or an air water syringe, because you want to avoid splash and spatter onto your eyes, your nose, your mouth, and your clothes. Okay. There's nothing wrong. But when COVID hit, when SARS hit, in 2002, I actually handled exactly what we were doing for COVID, but we did it for SARS, for the whole school. We had to take temperature, I said. You have to ask questions before they walk in, and let in very few patients at a time, and wear PPE. See, I used to use N95 and P100 respirators in 1993 to 1997, when I used to go and see TB patients in the negative air pressure room every week. I used to do that on the grand rounds. Sometimes I had to go pull a loose tooth out there. Yeah, those are difficult to use. The breathing is hard to them. Yes, all those things started off being implemented in the medical facilities in 2002 because of SARS, then in almost close to 2010 because of H1N1, and 2015 because of MERS. We started doing it in dentistry full force, and it became a guideline or a recommendation only because of COVID. And COVID is a bad thing. It's highly infectious, and it shows results immediately, unlike TB. Now, so you got to, use your PPE based on anticipated exposure to the risks. Okay. Hand hygiene. Oh my God. When I was in dental school, when I started practicing dentistry in the field, this is way before gloves became mandatory. In India, I washed my hands before a patient, after a patient, when I was leaving the place. I used to wash my hands and get into my bike or my car and then go home. Today, just because gloves were introduced, people have stopped washing their hands. On the other hand, they use a hand sanitizer. If you have dirty hands and you just use an alcohol-based hand sanitizer, it's going to fix all the dirt onto your hands. The best time to use your hand sanitizer is to use it immediately after you wash your hands and dry your hands, to get that extra kill effect by the alcohol.
Well, not just that, but the alcohol itself, if the bacteria has a glycocalyx, it's actually just going to spread the bacteria all over the place. It's not actually going to kill it.
Exactly. Yep, yep. See, alcohol, you remember when we were doing botany or zoology, we used to use Aquanet hairspray to stick the things onto the glass slide, the substrate onto a specimen onto the glass slide. Alcohol sticks dirt and grime onto your hands, onto a surface. That's why even in disinfectants, I say use a water-based disinfectant rather than an alcohol-based disinfectant. So yeah, you're right. And the glycocalyx of certain microbes, I mean, this one doesn't do much. Uh, Alcohol doesn't. In fact, we use alcohol to preserve spores, if you remember. Yeah. Hand hygiene, it has to be done. It has to be taught as a science. And then today, when everybody, you remember we were talking about implantology. Every dentist is now placing implants. That's a beautiful thing. Cost of implants have come down considerably since when I started dental school to now. And guess what? People are not following safe surgical guidelines. You remember we talked about that. This is going to hit the ceiling soon. Somebody is going to have a site infection because they have not washed their hands or they're not using sterile gloves. They have to learn about the surgical hand scrub, at least, know the principles of it and wash their hands twice as better as regular general dental hand washing. Okay, that's another area. Now, instrument reprocessing, there's a bunch of stuff which I've seen. People are doing it mechanically. Okay, when the instruments have been used, you separate out the waste, the gentle waste, and the regulated waste right at the chair side and the sharps as well. I tell people, put a sharps container in each arm, a small one. I even tell the person who used the sharp, the disposable sharp, to dispose of that sharp and not let a second person try and use it, like burrs, like scalpel, blades. If you're still using a Borden Parker, or if you're using a disposable scalpel, dunk it in, into the sharps container. Keep it safe for the next person to come and clean it. Then you have to take those instruments. I've heard horror stories of dental assistants actually picking up the whole instrument tray and sticking the hand pieces in a soaking solution and sonicating it, and then bagging it and sterilizing it.
That sounds very costly.
Oh, yeah.
That sounds very expensive.
I know, but this is what happens when somebody whom I know or a random dentist calls, Doc, what do I do? My hand pieces are not working. I said, talk to me about the process. And that person didn't realize they were doing it for the past few months with the new assistant who would come in. So see, everything was in silos in the clinic, and I don't blame people for that. But the problem is there has to be some information integration as to what's happening. And this guy, each handpiece costs anywhere between $1,600 to $2,700, depending on what you want in those handpieces. And instead of a handpiece going in for service every year, he was pretty much losing a handpiece every 6 months. And that's a lot of money. So, then after that, you have to think about instrument reprocessing. There are many ways to reprocess, and there are certain things you cannot reprocess. One of the examples is we all autoclave handpieces, right? I mean, that's a must, including slow speed handpieces. But there's one handpiece which is never detached from the device, and that is the hygiene handpiece, which we use, which you cannot detach the handpiece. It's connected to either the Parkel or the Dentsply, Bobcat or whatever the thing may be. And we only take out the tips. Have you ever taken that sleeve out, cut it, and dissected it and looked at the amount of gunk in it? It is horrible. But yet they still use those handpieces, but only take out the inserts. I tell everybody, every clinic, get rid of those, get a handpiece, that goes in either an ultrasonic or a piezoelectric handpiece, which can be detached and reprocessed, according to manufacturer's instructions, like autoclaving it, as a terminal end of the reprocessing stuff. Then another thing is everybody has been misguided on chemical indicators. I've gone into clinics. I've done at least about 800 clinics in the past few years. Walked in, walked through, and spoken to them as well as trained them. Most of the people who use chemical indicators think that it is a mandatory thing to use chemical indicators for every bag, for every cycle. Not necessary. They don't know the classification. CDC says it is you can, it is not you must. They don't know the difference between can and must. But most of those clinics have learned from dental industry that are selling the supplies to them. By the way, you remember I was showing you the data on the digital indicator which I worked with on Maxim? And the digital indicator shows that even the biologic indicators of the spores only measure up to half the cycle. And all these other chemical indicators, including integrators, have been pegged to a biologic indicator because they wanted a 510 equivalency clearance, a 510K to the FDA. So people have to go through and never break a cycle. You don't need to wrap every bag unless it's a surgical kit, because it's good to have the wraps. When you can open up the wraps, the inside of the wrap is a clean surface, so you can place your instruments on that. Well, but for general dental purposes, you can still use your pouch, which is the easiest one for the assistant to bag in. Then people don't realize.
I think one of the things that people don't know, and there are some dentists who know this, I know, but I know that there's a lot of dentists I talk to who have no idea, is the differences between a pouch, a wrap, and an unwrapped instrument, and that it's entirely okay to autoclave instruments unwrapped if they're going to be for immediate usage. The wraps and the pouches are simply to maintain a sterile environment for as long as possible. So I think that people don't realize that. Can you give us some timelines on that? A pouch versus a wrap versus a naked instrument, on how long they're sterile coming out of the autoclave, so that people have that information out there.
Right. So an open instrument, an open instrument sterilization is considered a flash sterilization normally. And most of the agencies do not like it, and they have not approved it. Okay. So if you're using an unwrapped instrument that goes through a complete cycle, it is only for immediate use, then and there. You cannot store it in another pouch. You cannot. I've seen that happening in a lot of clinics where they actually autoclave the handpiece naked, because somebody from the 80s has, or late 90s has told them it's okay. And then they put it into an unsterile pouch. It breaks the whole cycle issue out there. So you cannot store naked instruments. And another thing is, we have dentists who have come from all over the world, and dentists who have been trained there and come here. And then they've seen the ultraviolet boxes, not boxes, these are called cases, or what you call cupboards. They autoclave the instrument and then they stick it into that thing and use it 5 days later. Those things do not work. You can actually, if you dump the whole thing into a broth, we'll have some beautiful colored growths, So you do not do that. If you're going to use, the flash sterilization was actually a cycle that was designed. If I went in for a hip replacement, the implant which goes into my, my femur and my hip area, by mistake, if it got contaminated, let's say we had a person with butterfingers and dropped it on the floor, the implant, they would immediately take it, clean it, and then sterilize it naked and bring it back immediately. And during that process, it would take about 10 minutes. They would keep me alive, by giving me a little more blood, by stabilizing me. That is what it was meant for, not for dentistry. You know, the next thing is, there is no, to be frank with you, there is no timeline for storage as sterility is concerned. If the seal is good, if it does not allow external contaminants to get in, you can keep it till the cows come home. I'm talking of months, years. Yeah. The reason
That's actually a new one on me, because I was under the impression
Sure.
that the barrier of a pouch was a semi-permeable membrane. And because of the fact that it was semi-permeable, that it would go bad after, I believe I was told, a month in school. But, maybe they were just telling us a load of BS, that someone else had told them. So your official statement on that is, as long as it's been sterile and the seal is still good, you can have an assumption that 20 years from now it's still sterile.
See, the thing is, it's like, where can you preserve it well? In a dry area where there is not dust or other humid contaminants which can get on a pouch. If it is kept in a decent, dry, clean environment, like in a cupboard, you can keep it for, as long as you can. And then nothing, the barrier should not be torn or broken. Okay. There should be no water stains on it.
So let's say somebody does a sterilization run. They do a full 25 minutes. They open the sterilizer. They are allowing it to outgas or dry, but they don't have time because they have a patient in the chair. They pull it out. Now, all of the other instruments in that run did not actually get the drying cycle. And so those instruments are not going to remain sterile for as long as a complete dry cycle instrument would. Are those instruments even considered to be sterile at that point or not?
Well, if you can dry it immediately, without let it go through a complete dry cycle. Let's say, for example, you had to pull out what they call an implant handpiece immediately because the other one stopped working. Okay. You can take that implant handpiece out, and if the cycle is not completely dry yet, close it back and run another cycle. There's nothing wrong in that.
Hey guys, now a quick word about our sponsor. I'm really excited to announce that we've partnered with United Medical Credit to offer an exclusive deal just to TBOD members. Now, United Medical Credit is a patient financing provider with a unique waterfall lending process. It allows them to approve a much wider range of applicants. In fact, the widest range of applicants in the entire field. I've been using United Medical Credit in my practice for a couple of years now, and I'm seeing great results. They really speak for themselves. I see at least 30% increase in the number of patients who are actually approved whenever going through UMC. And the best part is, patients are accepting treatment. More acceptance, more patients means more revenue. Right now, they're offering TVOD members a special discount of 0% merchant fees until the end of the year. That's right, until the end of 2021, you get 0% merchant fees charged. And they're going to give you a 30% discount for life after that. Now, if you want to claim this offer for your practice, go to www.unitedmedicalcredit.com/TBOD, or as always, you can go to Dockoff Investments, click on the deals section, look up UMC, and register. Thanks a lot, guys, and UMC, thanks for sponsoring.
Okay. But don't take wet instruments out, because wet instruments coming out, there is no assurance that it is sterile. It's going to stay sterile. You got to put it on a surface somewhere. There'll be contaminants on the surface.
And it can wick.
Yeah. It can wick. Exactly. And that's what, that's another thing which I've seen in dental clinics is, be it a Midmark, Tuttenauer, Sycan, or whatever the thing is, a lot of times people ask, go check the bags. There'll be water spots on the bags, or there'll be still water beads inside the pouch. Then I asked them, did you stack it? Then they show me, no, this is how we place it. Then I said, why don't you call the technician and increase the drying part of the cycle? They can do it from on the board. They can do that. They have to come out dry. If they don't come out dry, you cannot effectively store them and be assured. Now, how long can you store it? The thing was, it was incident dependent. Suppose there was a tear. The minute the tear happened, the instrument is considered non-sterile for storage. You can use it immediately, probably, if it happened in front of you. If you break a pack, you use it. Otherwise, you put it through the whole cycle again. It was an incident dependent length. But then what happened was, in hospital systems, they started having issues with people, not logging in what instrument came. They had barcodes. Some good hospitals had barcode systems where you would know exactly which patient you use what instrument on, just to make, in case they had a post-op infection. Okay. That is why time-dependent thing came in, but more so in the hospital field. I have not seen the CDC in their recommendations saying that it can only be stored, or it has to be color-coded. It can only be stored for a week, a month, a year. No. It is incident-dependent as far as I'm concerned and as far as science is concerned. Now, if they work for a system, like let's say I work for a hospital system, if they say you can't keep it for more than a month, that means I'd have to put the date just before I stick the thing into the sterilizer, either the sterilization date and the expiration date, or if you have a barcode, you can put the thing in, and then you can go back and rescan your barcodes and then take those things out which have been, but it is not mandated through science. And I have not seen it for dentistry yet.
So let's talk a little bit about troubleshooting. A lot of times people have issues. You were talking earlier about overstacking, stuffing the sterilizer, which can cause beading, which can cause rust, which can cause things not to ever get sterile again, right? Let's talk about the appropriate use of surgical milk, when it can be used, what it should be used on. Let's talk a little bit about some of the things you may see go on with your sterilizer that people can have an easy idea of what may be wrong. For instance, water beading, packages that aren't completely dry, steam escaping during the cycle, and all of that. Because one of the things I think people really need to know is that these indicators are an indicator that something happened at some point during the cycle, not that the cycle was correctly done. And so your indicator is going to indicate one thing and only one thing, and that is whether or not it got up to a certain temperature, which is almost always dependent upon the pressure, because PV equals nRT, right? So basically, it's an indicator of only one thing, which is the pressure. So if it didn't get up to the pressure for the right amount of time, it didn't get up to the temperature for the right amount of time, you are never going to know if that pouch is truly sterile. You just know it a snapshot in time that it was at the appropriate conditions to become sterile if it remained at those conditions for, 25 minutes. So let's talk a little bit about what they can look for in addition to those indicators on the packages to know that their sterile runs are in fact sterile, besides just spore counts, because everybody should be running a spore count at least once a month. So
once a week.
I'm sorry, you're right. I'm sorry. I was about to correct myself. Once a week. So
once a month was for India. That at least I said you should at least do it once a month, but that was for the Indian subcontinent. But anyway, so number one, know how to reprocess and clean the instruments. Okay. Now, if you have hinged instruments, in the past we used to always go ahead, do the cleaning, do the pad drying, and then we used to drop the sterilization milk. It is basically, it does not allow rusting or galvanic currents that can happen when dissimilar metals are there. That is one. The second thing is it'll stop the corrosion on the hinged instruments. Okay. But today, actually, what I've seen over the past few years is the formulations of the ultrasonic machine's cleaning solution has changed to incorporate the anti-rust, anti-corrosive items. Then, even for the instrument washers, they've taken care of most of it. At least in the US, I have not seen corroded hinges. The only time I see corroded hinges is when the sterilization or the drying cycle is not effective,
or
and there's
cheap
humidity.
Chinese instruments.
Pardon?
Because I said or cheap Chinese instruments, because the
Oh, yes,
stainless
of
steel that
course.
we use here in the Americas, the
Yeah.
carbon is fixed, whereas the cheaper, softer stainless steels that you can get overseas, it's not, and you'll still get some rust and pitting on those.
Oh yeah. No. I don't know. We practice in America. We only take US dollars or maybe euros sometimes from patients. But we want to buy Chinese. We want to buy Indian or Pakistani or some sub-Saharan country or some lesser developed country devices that we use to treat a patient. And we you've seen this on our social media. Sometimes it breaks my heart when I see a dentist, challenging. Why should we pay $1,600 for a handpiece when I can get it for less than $100, on Alibaba? Because the handpiece that costs them $1,600 goes through testing. They use better materials to manufacture them. It costs a penny. I've been to places they manufacture dental units to these instruments. And I know what goes into the quality control. And apart from that, going through the FDA or the CE clearance, it is a lot. And they don't go through it only once in their lifetime. They have to show repeated annual, biannual tests that it works. That means they have to maintain a lab and run the standardized specification tests to show. And then the FDA does look at the data through independent evaluators. Amy looks at it. Yeah. You brought that point up, Chris, and I feel sad. Why do we need to? And then that's one thing. Why don't we spend our money for American things? Things made in America.
I don't know. I'm biased. I like German things. I feel like the
Sure.
Messinger burrs and the German
Sure.
German made forceps are far higher quality than most of the ones that made in America.
Sure. Like Cabo, WNH, and yeah, I know, but American things are not bad. German things also go through the clearance out here. The ones sold in the US. Buy it from reputable dealers. Don't buy it on, what do you call, what is that, eBay or Alibaba or somebody selling it for non-medical purposes on Amazon. Buy it from the dealers. That's true. But I don't have anything against it. Against buying good stuff. Now, so the sterilization milk, that has been taken care of for most purposes. If you still want to, you can still get it, but you use it after you clean your instruments, pat dry them, apply a drop at the hinged areas, and then bag it and stick it in. You're fine. So that is one. Then when you load your instruments, don't overload your instruments. That sterilizer is not going to run away. I should ask a dentist, is your sterilizer running? And then if they go check it and they say it's running, I'll say run after it. No, I won't do that. It's going to stay in your clinic. So run multiple batches with just the right amount of instruments. In one place where I had to go investigate a clinic, it was a public health clinic. I found close to 35 bags of instruments stuck in that small
in an
little
11
side
inch?
pan. Pardon?
In an 11 inch?
No, not 11 inch.
Okay, I was going to say, how did they even fit that?
No, the Cycan. You seen the flat Cycan one, which has just got one tray that pulls out?
Mm-hmm.
I saw that many stuck, literally packed into it. Somebody
Wow.
sat on it and then shoved it. And
Just wow.
when I saw that thing, I just went berserk. I said, well, I'm not going to go any further. I called the people who told me that, they were planning to spend about $14,000 or $15,000 on me to go and evaluate 5 clinics. On the second clinic, when I found this, I said, nope, I'm not taking any more. You pay me $4,000 for these 2 days worth of evaluations, and then fire them. I told them to fire them. And then they fired that company, that entity that was running the public health clinics for them. It was a large one for Dallas-Fort Worth area. So I've seen that.
So as a rule of thumb, for anyone who doesn't know for some reason, your instrument cases, your cassettes, just shouldn't touch each other. That you shouldn't be stacked on top of each other. Single layer. Now with
single layer is
individually wrapped
good
instruments,
if you
is two layers.
Yeah.
You have to have an air
Yeah, 2 layers
circulation
is
room.
good. Another thing is, instead of laying them flat, if you can get an insert, the tray thing which goes in, which is vertical.
Absolutely.
Yeah, that is a nice way of placing it as well, because that is the
gives you
ideal way.
circulation room on each side of the cassette.
Exactly. You can use cassettes. I prefer cassettes. Yeah, it takes more cycles to reprocess, but they are so handy. Now, diagnostic instruments, you don't need to have cassettes. You can just put them into a pouch. But, like hygiene cassette, then items for surgery, items for implantology, those actually belong. There's a reason why you have a cassette and then the number of slots for them, because it's a series of instruments you may need. So, yeah, cassettes are great. And they have lesser amount of injuries too. Make sure that you place them in the cradles and not, like Willy Wonka would do in a chocolate factory, having funny things happen. Make sure that they're laid out properly, and then you close the cassette, before you stick it into the sterilizer or for reprocessing as well. So, and then another thing is the chemical dot on your cassette, which is pink that turns into a chocolate color. Keep an eye on that to see if it is sterile. A few months ago, I had one of the dentists call me, and she said, Raghu, we had a temp who came in, and did not look at what was sterile and not sterile, and picked up a non-sterile pack and treated the patient. And then she went to the same stack and treated the next patient. She treated 2 patients, and then that was a contract for the day. She left. And then when they realized that had happened, they went and called the patients and told them to come back for blood tests. I mean, she could have shoved it under the rug, but she said that I intend to call these people and test them for blood, and let the county health department know what happened. I said, you're doing the great thing, but make sure you talk to your lawyer as well, just in case things blow out of proportions. We all make mistakes. Mistakes happen. And that was a true mistake. They had not told the temp worker that this is sterile, this stack is sterile, this stack has still to go through reprocessing. And what they were still using was the pink dot turning chocolate color. Why don't you use the zebra tape on even a cassette pack, or wrapped cassette, or wrapped case, or even a pouch? Just use the zebra tape, that beige color tape which shows that horizontal black stripes that go in. That is sterile. This is not sterile. I mean, at least not, it's not, it is sterile. It at least says that it's gone through a reprocessing heat cycle. Another thing I've seen very commonly is people reusing disposable items that cannot withstand heat sterilization. They stick it into glutaraldehyde. And that's wrong.
Most common one I've seen is impression trays.
Yeah, I mean, those plastic impression trays, a lot of those things are single-use disposable. Then there are reusable plastic impression trimmable trays, which can withstand. And you got to actually, and those cost extra money. They are as expensive as the steel trays, the metal trays, because they can withstand sterilization, but they can also be trimmed. We can't trim a metal tray. So if it is a single-use disposable item, dispose of it. Do not reuse it. Another place where I've seen is, those cheek retractors, and then photography mirrors, which we use in intraoral mirrors for photography. I think that, there are still, reprocessable mirrors available. There are reprocessable, cheek retractors. I've seen air water syringe tips and suction tips, disposable ones in, glutaraldehyde. I mean, that kind of blew me off. It was like.
I actually have something I do in our office for mirrors. And what that is I will get a package of 100% cotton socks. You have to find the ones that don't have elastic in them because the elastic is not autoclavable.
Yeah.
But you can take those mirrors and you can slide them into that sock and then put that into a sterilization pack and you can sterilize it, and it sterilizes. And it also keeps your mirrors from getting chipped and from getting ruined by that constant.
Or scratched, yeah.
So for anybody who is worried about that, it's actually a really valid concern, because if something is rough or scratched, like a mirror that's been scratched, it does not sterilize correctly. So you may want to do that with your individual mirrors to keep them from, getting scratches on them and ensure that you have a good sterile cycle.
True. I mean, I've seen them putting it into muslin cloth, wrapping it up. I've seen that being done in San Antonio. Yeah. Sorry?
I said like little mummies.
Yes, exactly. Yeah.
So do we have a number 8 on this list? Do we have a number 8? Do we have a number 8 on this list here? For those of you who are watching on the video, he's got a list of the things we're covering here. Let's go ahead and let's jump. Well, actually, we kind of covered number 8 already, the water treatment system.
Right. No. Water treatment, no. That is a biggie. That's the worst thing. The first thing I'd ask every clinic is, do you test your water lines once every 3 months for every chair? That's a requirement. That's a CDC's guidelines, which has been there. CDC's guidelines are nothing but recommendations which state boards require you. The reason why I keep saying that is, number one, I've tested pretty much every single item that is there in the market for dental water lines. Most of them have gone through my lab for their EPA or the FDA submissions when I was a faculty in, at Baylor. Yeah. There have been deaths because of contaminants or microbes in the dental unit water systems, like Legionella. There have been many cases that had to be hospitalized. Recently there was a public health clinic out of California, Anaheim area, where close to 50 odd pediatric patients had to be admitted to a hospital because of surgical site infection. They were happily pulling out teeth and using the regular treatment water. They were not even using sterile water through a dropper, through a monojet syringe. And that clinic shut down totally. But these kids were hospitalized. They had to be taken to emergency and hospitalized and treated with mega antibiotics because they had bony infections of the jaws. Yeah. So there was a death due to Legionella in Italy. Now, these were cases that kind of blew us out of proportions at random. What if there's a surveillance of the dental clinics? Now, that is the tail end part, testing your water lines to see if they are more contaminated than 500 colony forming units. Now, what do you use for providing dental treatment water? What is the quality of your water? How do you clean your lines? How do you disrupt the biofilms? Do you have a shock protocol? Do you have a testing protocol? What do you treat your dental treatment water with? A low-grade antimicrobial? Or what? So that is, nobody knows. Not one clinic I've been to knows the true protocol. For surgical stuff, of course, we have to use sterile, water. We have to use a sterile delivery system as well. That's why most people go for, what you call a device with a peristaltic pump, and then they attach, what you call sterile saline or sterile bags. And then that is attached to a sterile surgical handpiece or an implant handpiece, and then you treat the patient. Or they use a single-use disposable monojet syringe with an assistant dripping water. So that is one topic. It's pretty long. It takes about 2 hours to go through and understand truly what you can apply in a dental clinic. So that's then dental safety and radiology. Make sure at least once in 2 years, you get a tech to come with their Geiger counter and everything and run through all the radiology stuff. Then, of course, for Texas, because you guys fry people, the state's boards of Texas requires you to have every 3 months a test done, an internal evaluation. You used to, to make sure you use that step test or the pin test or the coin test or whatever it is. You got to do that. Then another thing is the barriers I've been to most clinics where they've done pretty okay with hanging up the barriers, the lead aprons and stuff like that. But some clinics, I'm not joking, those lead aprons, when I shake them, I can hear crinkling. And they must have been, there for daddy long years. So simple things. Then also a radiation symbol. A lot of clinics don't even have a radiation symbol where they're going to be taking x-rays. And a lot of people don't even understand the radiation in dentistry is not that bad for a pregnant person. So educate your staff, read ALARA, ALARA, which is a very short poster document, whatever it is. And it also can look at pregnancy and radiation in dentistry. Okay, so those are some of the things you should learn from. So I'll be developing within a week. I'll have the form, a fillable form, which you can download from from where Doc is going to put up the podcast. I mean, where put up the podcast, I'll have the form ready for you. Let it be a self-assessment thing. It'll have a yes, a no, and not applicable, those kinds of things, which you can do it on a periodic basis, at least on an annual basis. Fill out those forms and stick it into your safety manual, And if you guys are interested in training, online training, self-paced, get your office on to Tooth CE. More the people per office, lesser it is per head. Even individuals can do that. And then from next month onwards, I'll be actually providing actual classes where you guys can register individually or as a whole, as a clinic. So that's basically today's presentation from my end, until and unless Chris has any questions, and we can do a wrap up on that.
Well, Dr. Puttaiah, thank you so much for your time today. Folks, if you want to find out a little bit more about what your team can learn from Dr. Puttaiah, go ahead and go to toothce.com. Take a look at the offerings they have there. There are going to be some new courses open this month. And, of course, Dr. Puttaiah is also going to get us that self-assessment sheet. We'll post that in the Business of Dentistry for everyone to use. Please comment below that post with any questions that you have, and Dr. Puttaiah will do his best to answer you. For right now, thank you for wasting another hour and a half listening to the sound of our voices. I hope that you receive some great actionable information that you can use in your practice immediately. Until the next time, this is Doc Huffpower and Dr. Raghu Puttaiah signing off.
Thank you. Thank you.
Hey folks, before I let you go, I just wanted to make sure I thank United Medical Credit for sponsoring this podcast and also the business of dentistry. Go check out their website at www.unitedmedicalcredit.com/TBOD to get a special deal.
Thanks for listening to the Dear Doc podcast, your source for the business and legal questions associated with your dental practice. Don't forget to subscribe to the Dear Doc podcast on all major platforms.